Okay, so there we go. So today we're going to look at, we're talking about orthoses. We're going to talk about some of the evidence behind how they work. So I'm not too sure who my audience is. It's always a bit tricky when you do webinars. I'm guessing probably most of you are podiatrists, but hopefully we've got a few physios, maybe some orthotists, and a few other health professionals too. So today is not about me telling you exactly how orthoses work. It's about going through some of the research and the current thinking and giving us a bit more of an insight. So for those of you who read my last blog, I talked about the time when I was quite newly qualified and I was on placement, and I had an afternoon with a consultant orthopedic surgeon in paediatrics. So as soon as I went in there, he asked who I was and what my profession was, and I quite proudly said that I was a podiatrist. And he immediately said that he wasn't keen on podiatrists, and he said quite soundly that orthotics do not work, just like that. And then he quoted a paper at me. It was the one by Martin, which was written several years ago. And basically it showed, or what this paper showed, was that foot orthoses didn't help prevent HAV in children. Now it's a great paper, but that was the only one he quoted, and that's what he based everything on. And I think really this is a typical example of reading just one piece of research, albeit a good paper, and not actually taking a step back and taking a broader view of what's going on. And actually that paper has been highly contested since by our profession. I think also he'd had some bad experiences with podiatrists making money out of orthoses that children didn't necessarily need, but even so, that really shouldn't have given us all a bad name. So I think the thing is, for most of us who are confident in prescribing orthoses, we know they work. And in most cases, I think we certainly think we know how they're working. But when we look through some of the papers out there, which we're going to do in a minute, it becomes clear that there's no consensus or no concise reason that everybody actually agrees on. Now, as a podiatry profession, I think it's important that we understand the research that's out there. And whatever our personal thoughts are, I think we need to be aware of the counter-arguments. So my run-in with a surgeon was a bit harsh, I think, and I hope that's not a common occurrence. But there are always times when colleagues might ask us questions, or even more interested patients. And the thing is, now we're in a world of internets and blogs and Wikipedia and so on and so forth, and you never really know what people are reading and what they're basing their opinions on. For some of you out there, if you work in multidisciplinary practice, I think it's important to fully understand the evidence behind what is essentially your part in the patient process. Because if you can explain it clearly to your colleagues, I think they're far more likely to see how you can help with the overall management of that patient. Have to excuse me a little bit. I've got hay fever today, so I don't know how my voice is coming across. So first of all, before we look at all the research, I'm just going to do a very quick, very crude breakdown of the different biomechanical theories. And it is very important to have an understanding of these to fully understand the research which some papers will be basing some of their theories on. Now, I think the key word in this slide here is theory. So none of the things I'm about to talk about are validated, and none of them have been proved beyond reasonable doubt. So first off, and one I'm sure you're all familiar with, is good old Root, and that is a debate in itself. Some of us still work to his theory, some of us think it's way out of date. But at the end of the day, clinicians have used Root's principles for years, and patients have got better. And also, he was the pioneer of biomechanical studies, and his theories form the basis, I think, of some of the modern ideas that we see more today. So in my basic little nutshell, Root pretty much talks about the foot having an optimum position, and too much supination or too much pronation can lead to pathology. And he talks about NCSPs and RCSPs, which I seem to remember when I was a student, I meticulously measured and wondered, was it 4 degrees or was it 5 degrees? And then I'd get my colleague to have a look, and they'd measure, and we'd say, no, it's 4.5 degrees. And he also talks about rear foot motion. One thing he doesn't say is that the foot should be held in neutral, and I think some marketing literature over the years has misquoted this for ease. But he talks about the foot moving through a neutral position. So it's all quite mechanical, and it's all very nice if you're an engineer. But the point to remember here is that it's not just the joints at play. So there's a lot of soft tissue, and that doesn't always follow nice, neat engineering principles. So Next, we're on to Kirby and his subtalar joint axis positions. So I did a webinar about this last year, which is still available on the LBG medical website under webinars. So if you want to recap, have a look at that later. But essentially, this theory focuses on the location of the subtalar joint axis and how the forces acting on it affect the function of the foot. So forces medial to the axis will supinate the foot, and any forces lateral to the axis will cause the foot to pronate. So this theory is very effective clinically when you're thinking about where to apply your posting or how much. So it's very useful to know, but again, it's quite engineering based. And then we've got sagittal plane theory. So this looks at the works and the thoughts of Dannenberg and Craig Payne. And this theory looks at the three natural body rockers, which is the bottom of the calcaneus, the ankle joint, and the first metatarsal phalangeal joint range of motion. And it goes on to suggest that any interference with these three natural body rockers may lead to pathology. Now, there's certainly a lot of research focusing on the movement of the first MPJ, and it certainly looks as if that movement or the movement of this joint can have a knock-on effect on other parts of the body. But as for the other two theories, it is very engineering-based. So, as I said before, despite being almost the forerunner, if you like, of biomechanical theories, Root has been well challenged, particularly over the last 20 years or so. So McCoyle and Cornwall analysed 50 young adults in a study, and they found, and I quote, that the contrary to a previously published study, so they're referring to, previously published theory, and they're obviously referring to Root there, the neutral position of the rear foot for the typical pattern of rear foot motion during the walking cycle was found to be resting standing foot posture rather than subtalar joint neutral. And then McPoyle and Hunt also suggest that Root's theory has problems with measurement technique reliability, criteria for normal foot alignment, the position of the subtalar joint between mid-stance and heel-off during walking. So basically from all that, they then go on to propose their own model, which is the tissue stress model. And many believe that this is now actually a more effective way or alternative way for evaluating and treating foot disorders and prescribing orthoses. So the tissue stress theory mainly encourages clinicians to, and again I'm using that word, think like an engineer, and direct mechanical foot therapy towards resolving tissue stress in order to reduce the magnitude of the forces on the specific tissues that are injured. I suppose a very common typical example of that would be post-tib dysfunction. So this theory also promotes us to make predictions about which structural components of the foot are under tensile, compressive or torsional loading stresses during weight bearing, so that we can then design our orthoses accordingly. So really, I think it's a lot more about focusing on the structure which has the problem and trying to reduce the forces around that structure rather than making a foot function around the neutral position. So it's a sort of slightly different way of looking at things. So as I said, that's a very basic, very crude background on some of the biomechanical theories, and it's definitely worth reading up more on those. But with this in mind, I think we really need to think about the research and what the research is actually looking for with regarding how orthoses work. Now, I think we're all guilty sometimes of just reading an abstract or just reading the conclusion, and I'll put my hands up to that as well. But when we're trying to understand exactly how these devices work, I think we need to look a little bit further at all the papers out there, and sometimes, as you'll see in a minute, that can be a little bit of a minefield. So one of the first things I think we need to think about is what is the research actually addressing? So are we looking at papers that are studying or researching changes in motion, in which case we need to question how this is being measured and how reliable it is? Or maybe they're looking at symptom improvement, but then we need to think about other things like sample sizes, bias, or other factors which might be contributing to symptom relief and so on. And then you've got prospective studies and retrospective studies, and after all that, we need to think about how the foot position is actually being defined and how well they've described that. And once you've gone through all that, and when all's said and done, the big question is, how do they actually think the orthoses have done their job, and how valid is that? Now, here's a list of papers which I've lumped together, and I've nicknamed the supporters. This isn't all the papers out there that support it, this is just a few that I've picked off, so there are plenty more. But basically, all of these papers agree that orthoses change rear foot motion. So what they're saying is that by placing an orthosis under the foot, it changes the way in which the foot functions. So just looking down that list there, we've got Bates, who said that orthoses modified lower limb mechanics, and then we've got Novick, and Kelly. They concluded that orthoses changed a number of different things, including calcaneal angles and velocity, and I think I seem to remember they used the Vicon to measure that. And then you've got Genova and Gross, and they also supported that it changed calcaneal eversion. And at the bottom, McLean found that orthoses significantly decreased maximum values in the rear foot eversion angle, also the rear foot eversion velocity, and the internal ankle inversion moment. However, that paper in particular did conclude that it was unclear how custom foot orthotics influenced lower limb dynamics to produce positive clinical outcomes. So they couldn't actually prove how that was. Excuse me, I'm just going to take a sip of water. So I think what you can really see from this slide is that there's a whole host of papers out there showing that orthoses alter rear foot motion. And if we do indeed think like engineers, it makes sense that if you alter the angle of the calcaneus externally, then this will have an effect on everything else. However, and as we talk of physics, and as our friend Isaac Newton would say, for every action there's an equal and opposite reaction, and here we have it. So this is a list of papers which I've named the opposition, and it pretty much opposes what the last slide said. So what have we got? Blake and Ferguson suggested that rear foot posts have a somewhat limited function in foot orthotic therapy, and they also said that the choice of posting material is of limited functional value. And then Stackoff showed that medially placed foot orthoses didn't change tibiocalcaneal movement patterns substantially during stance phase. And actually in that study he used bone pins to analyse it, so you could argue that this paper could be more relevant because he's measuring what the actual bone in the joint is doing rather than trying to assess it through the skin. Then we've got Stackhouse found that orthoses don't differentially affect rear foot motion of a rear foot heel strike, but he's just looking at the heel strike there. But really the aim of this, and what I hope you're starting to see, is that these papers really are just looking at changes in motion. So all my supporters and all my opposition there, every one of those is focusing on whether orthoses change motion. Right, in 2000, which is a few years ago now, Landorf and Keenan did a literature review of the papers to that date looking at the workings of foot orthoses. And they concluded that it was generally positive, although obviously like I have, they found fors and against. But what they found was that most of the papers showed that orthoses not only worked, but they made changes to the patient satisfaction, pain and deformity, plantar pressures, the position and motion of various joints in the foot, muscle activity, and oxygen consumption. What they also said was that there were an awful lot of difficulties which arose from researching foot orthoses, and some of that we have discussed already. Now at this point I'm just going to pop an odd slide in here just quickly about the foot posture index, and I talked about this more in depth in my last webinar looking at assessments, but basically it's a validated series of tests to look at and determine foot posture, and various different studies have used this as a measure, and I've just listed those ones there. So often I think when we pick up a paper we look at the variables in the piece of research, and if we see something that has maybe 100 or 200 army recruits, and then it says that they've all got similar fitness levels and they're all a similar age, they've got a similar physique, height, so on and so forth, and you think they've kept those variables really concise, but often it doesn't say that much about what their foot posture is doing. So studies which do incorporate the foot posture index usually mean that they've considered foot posture as a variable in itself, so that is just a point to bear in mind there. So do orthoses provide clinically meaning improvements? I'm going to look at a few studies now which relate more directly to conditions, so they're a bit more clinical in approach. Richer carried out this study, and they did a meta-analysis of 23 randomised controlled trials on the use of orthoses for lower limb overuse injuries. So they summarised that the current evidence supports the use of orthoses to prevent first-time overuse injuries, but that the evidence was insufficient to recommend them for treatment for for overuse injuries. So good for preventing, not necessarily for treating once they've got the condition. What they also pointed out was that the research base was very poor, and that many papers related to military personnel, which wasn't necessarily representative of a normal population. What they did put in their conclusion, however, was that because there's a potential low risk of using orthoses and potential high benefits, that they would in fact recommend the use of orthoses for the treatment program for your patient. So even though the evidence wasn't great to back it up, they would indeed recommend it. Can orthoses prevent lower limb injuries? So this paper is in contrast. Matilla concluded from a randomized controlled trial of 228 participants that routine use of insoles does not prevent physical stress-related lower limb injuries in healthy young male adults. Now, one thing to note with this paper is that the orthotic insoles which they used were only just moulded to the patient's foot to provide support. So it wasn't really addressing any specific biomechanical abnormality. Now, the reason I've included this paper in the presentation is because I have had it quoted at me before by another health professional who was quite anti-orthoses, and this is what he used to back up his opinion. So needless to say, I have given him quite a long reading list now, but again, this is the dangers of reading just one article. So, knee pain. Can orthoses help with anterior knee pain? That's something that comes up quite a lot. Well, yes, according to this paper by Mills. So it focuses on anterior knee pain and looks at whether orthoses help in the short term rather than just leaving the patient and doing nothing and seeing if it clears up on its own accord. So it's based more on outcome measures, but what they found was that using orthoses showed greater improvements. However, again in this study, the orthoses prescribed were based on comfort rather than what they thought was needed biomechanically, and I will come back to that point later. In their conclusions with this paper, though, they offered no explanations as to how they thought the orthoses actually did improve symptoms. And do orthoses reduce pain in patients with pronated feet? And again, according to this one, yes. So again, another recent study, and Shear looked at 24 runners with a pronated foot and knee pain. And what they found was that by adding a medial wedge to an orthosis, this gave relief while running on a treadmill for 60 minutes. Now, with this paper, the follow-up was only 2 weeks, so it is difficult to draw any long-term conclusions from this. But with this study, they are aiming to counteract the forces seen with excessive pronation rather than just giving a standard orthosis, and this seems to have worked. So, right, Eslami looked, or they focused more on the kinematics aspect of orthotic intervention in this study, so they went into a bit more depth about how the devices worked. And they looked at changes in magnitude and timing when orthoses were used. And what they found was that foot orthoses could reduce rear foot eversion, and they suggested that this could be associated with a reduction of knee adduction moments during the first 60% of the stance phase of running. They also concluded that modifying rear foot and tibial motions during running couldn't necessarily be related to the reduction of ground reaction forces. And they also noted that changes in magnitude and timing of the rear foot eversion and tibial internal rotation of the orthoses and their contributions to ground reaction forces were not necessarily well understood when they looked at knee joint moments. So there's a lot of information from this paper, but as I say, they couldn't draw any real conclusions from it. So this study by Barton and his colleagues, they focused this on the pain reduction in the study of 60 patients with patellofemoral pain. I think they were all aged about 18 to 35. And the results show that orthoses provide significant improvements, and as you can see from the points I've put there, but these authors hypothesized that foot orthoses work not by changing the motion, but by enhancing the afferent feedback from the cutaneous plantar receptors of the foot. So that was their theory, but what they do say as well is that there is an absence of research evaluating the neuromotor effects of orthoses. and we've got another fairly recent paper here, and this looks at 400 military trainees, so a nice big research group there. So it was a randomised control trials, and the authors found that the group with the orthoses had significant reductions in medial tibial stress syndrome, also compartment syndrome, and just injury in general. But yet again, what they've said in their conclusions is they've got no idea why this is happening. The other point I would add to this is that the exact pathogenesis of medial tibial stress syndrome is still not fully understood. So, in my opinion, I think this would make it even harder to try and understand how the orthoses have worked, because you don't know exactly what you're dealing with or what you're tackling. So, let's look at muscle activity. Now, this study, it looked at the effect of barefoot, shoes only, just a heat-moulded prefab orthotic, and a 20-degree inverted custom-made orthotic. And what they looked at was muscle activity. So the findings were that both types of orthoses significantly altered amplitudes in the tib post muscle and the peroneus longus, but they found that only the modified prefab device changed peroneus longus amplitude towards what they described was a normal pattern with a normal arched foot. So again, they note that the research in this area is very, very rare, variable, and that more good research is needed. But what I think is interesting from this paper is that it's the orthosis which is probably the more comfortable one, which creates a more normal muscle activity. So that's just my interpretation of the paper, but it's not the device with the more posting on it which seems to have made the biggest difference here. Now I've chucked this one in, and we've talked about different theories. We've talked about changes in motion and magnitude and engineering principles, and we've looked at muscle activity and a few thoughts on neuromotor effects. So this is a recent paper, it's only 2015, but we've almost gone full circle back to our biomechanics roots. Cha-ching. So, as I said, only a few months old, and basically it's only a series of case studies, but what these authors suggest is that growing pains in children are the result of chronic subluxation of the subtalar joint, which creates transient synovitis with referred pain into the lower leg. So what they suggest in this paper is that by controlling subtalar joint motion, then you will prevent this or cure the problems that they're getting. Now, I did mention this paper in my last blog, and I'll say it again, I haven't critiqued this in any depth, but nonetheless, it is a paper which is offering an explanation to how orthoses work. So have a read and see what you think of it for yourself. So the science and the physics is obviously very important, but if we take a step back from trying to work out how and just look at the facts, sometimes listening to our patients will often tell us how effective orthoses are. And here's a list, and again, this is just a few studies, there's far more out there if you care to look. But what it shows is that over the years, all of these papers agree with the intervention of orthoses, and it shows that pretty much most patients end up getting better. So it kind of highlights that we know they work, it's just pinning down exactly how they work. Which brings in this slide. We know they work, but we're struggling to work out how. And I think this has long been the subject of the debate. So the papers I've mentioned so far, none of them have come up with a gold standard, uncontested answer to the question. So maybe we're looking at the wrong things. Maybe looking at changes in motion and muscle activity aren't what we should be looking for. Now, here's a chap with a whole heap of papers to his name, and he's a physicist, I think, rather than a clinician. And he's been researching and experimenting with biomechanics with his team for the past 20-odd, probably even more years. And a presentation he gave a few years ago that I listened in on, he said that in his years of research, experimental evidence had shown that skeletal alignment in general was inconsistent and subject-specific. Now, the interesting thing here was a lot of their research has been carried out in Scandinavia, and for some reason in Scandinavia, they're not too hot on the ethics of popping bone pins into people. So the data they're managing to accumulate there is actually very good. So how does Nick think that orthoses work? Well, he thinks that each joint has a preferred pathway, and that if an orthotic is comfortable, then it's more likely to be effective. So this is edging a little bit towards the neuromotor control side of things, which is what Barton touched on with his patellofemoral plane. pain. Sorry, I'm getting my words in a twist. And possibly it could relate to some of the other papers which found that orthoses which were probably moulded or more comfortable had a better effect than those which were posted highly. So, but again, that's just opinion. So what's preferred movement pathway? Now this isn't a new theory, but it's one that doesn't receive probably as much attention as some of the main ones I mentioned earlier. So in 1999, Nigg proposed a theory of orthosis function called preferred movement pathway model. And he suggested that this should actually become the new paradigm for movement and control of the foot and lower extremity. And this was all pretty much based on previous research which they'd carried out, and in a nutshell they suggested that foot orthoses don't function by realigning the skeleton like some of the more engineering principles have suggested, but in fact they alter the input signals into the plantar foot, which then causes a change in the muscle tuning. This then produces a change in muscle activity to try and dampen the soft tissue vibrations within the lower extremity muscles. So basically, if an orthosis allows the joints of the foot and lower extremity to take their preferred pathway movement, then muscle activity will be minimised. But if the orthotic doesn't do this and it interferes with this preferred pathway, then the muscle activity will instead increase. So there's lots of research going on in this area, and I think it will be interesting to see what comes out in the future. But sometimes I think maybe we're barking up the wrong tree with it all. Leonardo da Vinci, and this is very old research here, said a long time ago that the foot was a wonderful piece of engineering, and we've seen a lot of clinicians and researchers still think it's based on these engineering principles. But what he continued to say was that it was also a work of art. So I think maybe it's a combination of engineering, neurodynamics, and quite a few other things. And to bring it to conclusion, I think it's important to remember that orthoses don't work in isolation. So we often use them in conjunction with a variety of other treatments, such as stretching and strengthening exercises, perhaps changes in footwear, training modifications, and so on and so forth. And one thing I've put on there, and I think this is quite often neglected, is that it is very important to educate the patient, because that can be quite as important or just as important as the rest of your treatments. I think also in regard to the research, there's often a whole host of different devices which are used under the blanket term of foot orthoses. So some are custom made, some are off the shelf, some are bought straight from the shop, some are heat molded to the patient's foot. Custom made ones, they could be from different labs, they could also be relating to different theories, and so on. So there's lots of different variables there which makes studies very hard to compare. Also, some of the papers I've looked at have also been quite vague in describing what device they've actually used. So it says they've used a foot orthoses, but it hasn't really said much about what it is or what it's trying to achieve. Now, just on a final note, and this is a bit of a funny cautionary tale, I'm not by any means saying that research isn't important, because it is, but I think clinically we do need to keep it real. Now, a few years ago when I worked for the NHS, we had a new clinician join us who was very, very clever. He had a first-class degree in podiatry. I think he also had a first or something or another. He had a master's in physio, so very, very good addition for a multidisciplinary team. But his thesis, or his dissertation, or whatever it was he did, he'd looked at the evidence behind foot orthoses. He'd qualified, I don't know, 10, 15 years ago, so he didn't have any of the more recent stuff. But he'd come to the conclusion that there wasn't any sound evidence for them, and this really affected the way he practiced. So not only was he not keen on giving orthoses, but he also told the patient all about this as well, and often they just sat there looking completely amused and just not really know what was going on. Now, I think the moral of this was most of his patients, when some of the others, or some of us followed up his patients, most of them didn't really get better or improve. I think his private practice didn't go wonderfully well, and now he's got a very good job, I think, in academia, and he works for a university. So sometimes I think it's very dangerous to read too much research and get too wound up in everything that's been disproved, and not going necessarily with our gut instinct. So I think the moral here is, yes, they work, we know they work, but understanding exactly how they work is unclear. And I think there is a possibility that maybe different things work in different patients. So in some, maybe it's very obvious that you're going to put a rear foot wedge in and that will change the calcaneal angle, and then you can almost stand them on an orthosis and see the knee straighten up. And maybe in other patients, maybe it's more a neuromuscular development which they have, and perhaps that's why it's so difficult to pin down. So I'll draw that to a close now. There's a list of references there. I've got most of them on, but as you can see, it was a bit of a squeeze. So any questions? I forgot to say at the beginning, if you do have any questions, I think you've got the option on your little sidebar to tap them in and ask them. So if you do, I will try and answer.